Welcome to the Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm Dr. Andrew Wilner, and my guest today is Dr. Maheen Mausoof Adamson. Welcome, Dr. Adamson.
Thank you for having me.
Dr. Adamson, today we're going to talk about something that I think is really important: gender differences, particularly in relationship to head injury. Now, you are a clinical associate professor of neurosurgery at Stanford, and your interest is what happens to the brain, right, when it gets injured. And is there a difference between female brains and male brains in response to that injury? Is that right?
That's absolutely right.
So I guess a priori, why should there, well, at the risk of being politically incorrect, I will say that there are differences between men and women, correct?
Correct. Very much so.
We can all agree on that.
Yes.
What about their brains? Are there differences in their brains?
Sure. Let's unpack this a little bit. I wanted to go back to how you mentioned that I am a clinical associate professor in neurosurgery at Stanford, but my main appointment is actually at the VA Palo Alto. And I'm a clinical research director there for the rehab services. And what's really important, the reason I mentioned that is because my work has been in veterans a lot for traumatic brain injury. And that's how I got into it. So I got into this because I've been studying Alzheimer's disease, cognitive aging, and then I started studying traumatic brain injury. So the access to data that I had was, since 2005 or so, we, have data that looks at departmental data on men and women who veterans. And as you know, in the military, there's not many women, but the population of women who are in the military has increased a lot, like from 12% to maybe 17% now. And so the numbers are increasing. So we were able to look at the difference in gender in just symptom reporting. So even there was a glaring difference between how women report symptoms after brain injury versus what symptoms are reported for men. And because I'm a neuroscientist by training, I was like, they're reporting this, but what's going on in the brain? And as you know, anyone who starts taking even undergraduate classes in neuroscience, we always learn about evolution. We learn about how the brain, develops and how different parts develop at different stages. And there's always some paragraph in there and some chapter in that undergraduate book that talks about sex differences in the brain. And it starts with how women have smaller brains or smaller skulls, or they have because they're just made smaller in a way on general, and we have less blood in our body. I think it's 1 liter less or something like that. But I think it's important to see that there's a ton of research that has looked at the differences in the brain, in the anatomy between men and women. And there's 2 camps. One camp that says that, yes, those differences are biological, and the other camp says that it's an interaction with the environment and it's how you nurture. It's the nature versus nurture argument, right? But I think it doesn't have to be that way. I feel like it's more has to do, rather than with the structure, it has to do with the function of the brain and how you utilize it and how it develops into things that, women are better at verbal memory, men are better at spatial memory. And these are things that some people contest. There's evidence on both ways, but there are differences. And the old saying that, gosh, maybe 15 years ago, it was like men are from Mars and women are from Venus, that kind of stuff. It's not as cut and dry as that. So, but yeah, so yes, there are differences. I hope I answered your question.
So back to the military, there is head injury, and more women are on active duty where they're susceptible to head injury. So in terms of complaints, you said there was a difference between men and women reporting symptoms. What was the gist of that? Did men report more symptoms or different symptoms, or women reported more symptoms? How did that play out?
Sure. So again, I have to give credit to the team that I work with, and um, Dr. Odette Harris and other collaborators, and who have really done a lot of work on looking at symptom reporting. And symptom reporting is really interesting. So we were able to so we did a paper into 2020, and it was one of my collaborators, Max Gray. His last name is Gray, so it's Gray et al. And the paper, we wanted to really see the difference in symptom reporting. That was just about the difference between the gender. So what we did was we matched them. So we matched the sample of men and women on the type of TBI they had, traumatic brain injury, the age at which they had it, and how far it was from when they reported it, how far the TBI was. So when you match those TBI characteristics, and we looked at the differences in symptom reporting, what we found was women had more psychiatric problems that they were reporting years after the traumatic brain injury. Psychiatric meaning depression, anxiety, and PTSD. They also had more self-report of cognitive complaints. I'm having a hard time remembering things, and more than men. And the third thing we found was there was a little bit more of vertigo that was being reported. Now, some of this can be explained, that these are all like hypotheses that are either have been tested or are being tested. Some of this can be explained by some physical aspects. So women have, on general, a thinner neck. And this is actually one of our wonderful collaborators, Dr. Jam Gajar in neurosurgery at Stanford. And I remember talking to him once, and he's actually published papers on this as well. When you get, suppose you get whiplash, right? Or you're in a sports concussion, or you're in, and your head moves back. So if your neck is thin, muscles, the impact is a little bit different in men than it is in women. Women tend to have more balance issues. I have balance issues. I have vertigo, actually. That's not because of traumatic brain injury, but I know what it feels like. So that seems to be a little bit more prominent in women than in men. So a lot of the times you somehow can take these reporting of symptoms on face value and say, oh, women are just more verbal. They're just going to report more. It's not true. You can actually have them test on certain cognitive tasks and see the differences as well. That was not done in the study. This was just symptom reporting. So what I'm saying is some of the complaints you can actually go and empirically test them, and others you can just say that, yes, that's the report. So I think that's what we found.
So one of the possibilities is that just due to being physically different, the injury would be different. What about at the level of the brain itself? I mean, suppose we take, a male brain and a female brain, and we hit each one with a hammer with the same force. It's going to hurt. So there is possibility that how much it hurts might be different. And what about the healing? A female brain certainly has a different assortment of hormones. I mean, the
Absolutely.
neurons, as far as we know, are the same. But is there a way to look at that? Can it be studied?
Yes. So Andrew, I'm so excited that you asked this question, because scientists always study like one aspect of something, but when you're doing clinical translational science and you're actually working in hospitals and you're a scientist, what you get exposed to is like, okay, you're interested in epidemiology, you're interested in diagnosis, but how does that translate into actual treatment? How does that translate into what's happening in the brain? So I think what's clearly important is that in a way, you have to look at it from the perspective of if a woman gets a brain injury, how is the brain going to heal versus when a man gets a brain injury, right? And the trajectories are slightly different. I'll give you an example. Now, this is there's a caveat in this. The paper that I'm going to talk about has been reviewed and has been, we have some edits on it, but it's going to be resent for submission. So it is not published yet, but it has been reviewed. So the data that we have on this is we looked at structural brain differences. And the easiest thing that we could do with the small amount of data that we have is we looked at cortical thickness, which is the thickness of your cortex, how it changes after brain injury. One of the problems we have in brain injury is we don't have pre-morbid data. So we don't know what the brain looked like before the injury happened, right? But we're able to say, okay, that this is the data from men, this is the data from women, and this is what we can actually look at their MRI scans and see whether their cortical thickness is actually correlated with any of the TBI variables, or if it is correlated with any of their cognitive testing and stuff like that. What we were able to find was that in women, the cortical thickness was not coming back to normal, versus men, it came back to normal. Now, I just told you we don't have pre-morbid data. So you're like, what's normal? Normal is from literature, from healthy individuals, what we were able to find in journal articles, what cortical thickness it should be if you don't have brain injury. So
Like those growth charts they have for kids, you know, at a certain
exactly,
be a certain height. You know, it's not
exactly.
100%, but it's pretty close to
It
what
is
it
close.
ought to be. What it
Yeah.
ought to be.
And I think it's important because now why is it like this? One factor could be hormones, right? One factor could be not just hormones in the system, but also after menopause and when the hormones leaves, the estrogen, there's no estrogen and there's cognitive effects. Maybe that. The other aspect of it is sociological, so social determinants of health. So we know that women, despite being more educated than men, are more unemployed. They also live alone more than men. So this is true for the veteran population. This is also true for the civilian population. So there may be some external factors that are not helping them heal better. We don't know. But there's data that's coming out, and there's a lot of data that we have to still sift through. The other important thing I wanted to say was stuff like this is really crucial to address when you're trying to develop treatments. So, we had all these issues with, the pharmaceutical company who came up with the drug. I forgot the name, but it had to do. What was it? Ambient? Was it Ambien? There was a sex differences between the way that drug was metabolized by men versus women. So that has to do with pharmaceutical. When you're doing any other kind of treatment, so if you're doing brain stimulation, which is what I do neuromodulation, which is you basically stimulate the brain by using non-invasively, by using an electromagnet, an FDA approved protocol. Whether you do that, whether you do cognitive behavioral therapy, whether you are doing any virtual reality therapy, anything that's not invasive, you still have to take into account the fact that you're treating a woman versus a man. And how do you take that into account? You find out if they are below the age of for the menopause. You find out what phase of the menstrual cycle they're in. If they are after menopause, you find out when the menopause was. Those are factors that have to be taken into account, because just an example of brain stimulation, if you in women who were suffering from epilepsy, if you stimulate their brain, depending on the phase of their menstrual cycle, the neurons fired differently. So, and I'm not saying, if you knew this, then wouldn't you save money in a way? Like all these treatments, they're expensive. If you knew that this is not going to work at this time of the month, maybe do it later or something like that. You know what I mean?
Right. So, as an epileptologist, I'm familiar with that phenomenon. There are women, for example, who only have seizures during a certain phase of their menstrual cycle, and we target the treatment to that time period. I think this is really interesting because it's a basic tenet of medicine that we individualize therapy, right? One size doesn't fit all, and it may be that that applies. Well, you didn't. Were you able to control for size? One of the big differences in men and women is that men tend to be bigger and women tend to be smaller, and that applies to their heads. So, were you able to size match, take a lot of 5'2" women and compare them to 5'2" men and see if the differences went away, or if they
Yeah.
persist? That might be an easy thing to do. But I think even if you control for weight and size and muscle mass and neck differences, it sounds like there are more complex differences that we just need better tools to study. It's hard to put a micro pipette into the brain and measure, hormonal differences and differences in electrolytes and neurotransmitters. But I suspect as we can do that non-invasively, some of these observations may become better to substantiate. We will be able to measure real differences.
I agree with you, and I wanted to bring up the epilepsy thing because I know that you work in epilepsy, and um, I think one mention that you had about correcting for size. So in brain imaging, what we do is we always normalize with total intracranial volume. And if you, or so basically you are normalizing by the size of your, you know, the overall size of your brain. So we kind of correct for that. And there's other corrections that we do. But it's important to also know that these differences are there, but they're there to be appreciated, and they're there to help us create our care to be patient-centered. So everything becomes very precise and accurate and individualized so that you can actually treat the not just the symptoms, but actually the mechanism of the disease or the health problem that you have. And it again goes back to the basics of medicine. You think of the patient first, know the patient really, really well. So yeah.
Absolutely. Well, Dr. Adamson, we're just about out of time. Give us just a glimpse of your current or next research project.
Oh boy. I'm in the midst of submitting NIH grants and just working on some very important issues regarding long COVID, and specifically directed towards looking at the sex differences in long COVID.
Oh, I think that's fascinating.
It
That's going
is.
to be very, very interesting. And in a year or so, maybe we'll talk about that.
Yes, and I think one important thing I'm doing in that is I'm working with a huge consortium of people, wonderful collaborators and researchers across the world. It's an international consortium that the founder of it is at University of Southern California, Dr. Paul Thompson, and the consortium is called Enigma. But the idea of this, the idea of the work that I'm pursuing right now is to really figure out the neural and the peripheral biomarkers that can help us determine what long COVID looks like. So brain imaging, full on like blood collection to look at T cells, to look at the inflammatory markers, and to really put together whether any of this long COVID is going to lead us into other things like dementia, or chronic fatigue syndrome. So things like that, like what is it that is in store for us for people who have actually recovered? And is there a sex difference in this? And we've seen some data out there that shows that yes, there seems to be longer symptom reporting in women for long COVID. There seems to be some stuff going on in the inflammatory markers that is also, based. And there's my collaborators at UCSF are also working on it very heavily.
Well, it's very encouraging that so many scientists are approaching these pretty big problems. And Dr. Adamson, I want to thank you very much for a fascinating discussion today.
Thank you very much. It was very nice to talk to you.
I'm Dr. Andrew Wilner. Thank you for listening to The Art of Medicine. This program is hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on The Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com